Hi, you guys. Welcome to Ask the Egg Whisperer. I'm not going to be here that long tonight because my mother-in-law is in town, and I love my mother-in-law, and she never watches me on live. So I'm going to just give a shout out to her and say I can't wait to go home and see you, and I'm excited. You guys all know that I married my husband for my mother-in-law. See, I'm saying it publicly. Everyone knows now. She's the freaking best. Okay, so let's start, and here we go. So this first question is from Longs. Long says, I'm 47 years old and I want to conceive by trying every month. Please help. Longs, you're like every other woman over the age of 45 that reaches out to me. I totally get it. Like, of course we want a pregnancy with our own eggs. But at 47, that's likely the time where your chance of pregnancy is 0. I know. Like, hello, Miss Positivity over here, Miss Fertility, I can't even, I was going to say fartility, fertility cheerleader just said something that seemed pretty negative. But the reality is that once a woman runs out of healthy eggs, it doesn't mean that her desire to have a healthy baby disappears. That's just not how it works. And so if a guy was 47 and he wanted kids, we wouldn't be like, oh, you're too old. No, we would be like, oh, that's really great. Like, we'll help you. So it just breaks my heart that we don't have anything better than egg donation. Don't get me wrong. Egg donation is fabulous. And it's so great that we have this as an option. And there's so many different ways of doing egg donation, like egg banks and fresh egg donors. There's freeze and share. That's a plug for freezeandshare.com. For those of you who don't know what that is, go to freezeandshare.com to learn more. There's also embryo donation and adoption. So I would ask you, Longs, to reach out to a psychologist like Jana Ruppnow, talk to her about creative family building, and then see how you feel, because I don't want you to spend your, being young at 47, doing something and wasting more time trying to get pregnant naturally when the reality is that it just won't work. Do I want to be wrong? Yes, of course I want to be wrong. Of course I want every 47-year-old to get pregnant naturally with their own eggs. But the likelihood is close to 0. Okay, next question is from Moni or Monet. It's spelled M-O-N-E-E. It sounds like money. Moni. Hi, Dr. Aimee. Thank you. It's a beautiful name, by the way. It's kind of like Aimee, Moni. How about that? See, I can figure this out. Hi, Dr. Aimee. Thank you for all the great information you share. You're an amazing doctor. I'm close to 43. Did 5 rounds of IVF back-to-back for a year and 4 months. We've made a total of 13 embryos from the 5 rounds, and only 2 came back normal from PGTA testing, grade 1 AA. We transferred 1 embryo last fall, and it failed, and we want 2 kids. Should I do another IVF or go ahead for egg donor? Our last IVF cycle, 14 eggs retrieved, 11 mature, 9 fertilized, 9 embryos on day 3, 3 embryos on day 5, and all were abnormal, and I'm desperate. So, Moni, what I would say to you is this. Have you looked to make sure that your embryos are not mosaic? So that's a really important question to ask your doctor. And go through my embryo diamonds checklist. So the diamonds, acronym. It's basically an acronym for the 8 things you need to know about your embryos. So talk to them about the embryo quality, and see if the embryo quality is really, really good. Given the number of cycles that you've done, 5, I would say that if the embryo quality isn't very good anymore, it might make sense to consider other options like egg donation. I'm like the most stubborn person in the entire world. And so you guys have heard me say it can take 4 to 6 cycles even to get 1 healthy embryo, and that can be totally normal at the age of 42. So I feel like if you still feel like you have it in you to do 1 more cycle, I think that would be okay. But I also think you have my permission to stop and just to go and do what's going to give you a much higher chance of a healthy pregnancy, because most egg donation cycles, most of your embryos do have normal chromosomes for the most part, especially if you're using an egg donor who's, let's say, 25 years of age or younger. So something to think about. Okay, this next question is from Hillary. Hillary says, I'm 40 years old. I've done 3 retrievals. Out of 25 eggs collected, we got 2 morulas, and the transfer failed, and 2 day 5 blasts after using HGH untested. I transferred that. 1 resulted in a miscarriage, and I have 1 remaining 5-day blast. We plan to transfer now. If it fails, should we think about donor eggs? I feel like my numbers are just not great. Obviously, I would love to use my own eggs, but I'm totally fine with the donor. I just don't want to waste any more money and time if we eventually just have to go the donor route. Okay, Hillary, that's a really tough question. Sometimes you just save the best embryo for last. So the fact that you have 25 eggs, I do think that there's a pretty good chance that you could have a healthy embryo at the age of 40. So talk to your doctor about all the implantation tests that I usually talk about on this show. So go to my website, draimee.org, and put in what is ERA in the search engine, and you're going to learn about all the implantation tests that I do for my patients. So that's one thing that I would suggest you do before you transfer it again. And then the other thing is, why are you here? Like, what is the fertility diagnosis? Have you gone through everything ahead of time to make sure we're not missing anything? Have you gone through the TUSHY check? Are the tubes open? Are there any polyps or fibroids, scar tissue in the uterus? Is the sperm really good? Are your hormones normal, like TSH? Have you done all the genetic testing you think you should do, like chromosome analysis and a carrier screen ahead of, transferring this next time? So I know I asked a whole bunch of questions, but I would go to your doctor and say, what have you ruled out for me? And then go through whatever it is and see if there's anything else you might want to do before you transfer it again. And ask the doctor, if this transfer didn't work, what else should I be thinking about related to things I could do before we transfer yet again if I were to use a donor embryo? And it's possible that they might say, oh, you know what? It looks like you might have adenomyosis, and I didn't tell you, or it wasn't as clear to me, not that they didn't tell you, but I think it's important to ask those questions up front before you transfer your one last embryo. And sure, egg donation is going to give us a better chance of pregnancy, no matter, if a woman's over the age of 35, using an egg donor is going to give us a better chance. That's just the reality. And at 40, using an egg donor would give you a higher chance because, if you think about the statistics and probability, 1 out of 10 eggs will be normal at 40. And I just actually did this calculation. I went, I think it was something like 9 eggs at 40 gives you an almost 30% chance of pregnancy. And then 9 eggs at 30 gives you something like a 90% chance of pregnancy. I have this little egg calculator tool that I use when I counsel my patients, just so that they have an idea as far as like how many cycles they should be doing from the very beginning. So just something to think about. Okay, this next question is from Emily. Emily says, I'm 37. We've been trying to conceive for over 6 months. My OBGYN wanted me to try progesterone before going to a specialist. My issue is my thin lining of 5 millimeters. What can help my lining? So I would talk to your doctor about whether they've ruled out Asherman syndrome, so that's scarring of the uterine lining, and then talk to them about a hysteroscopy procedure. You can also do a hysterosalpingogram, and then have them look in and see if there's anything they can do to repair the uterus before you move forward with, a healthy pregnancy. There are also some hormones that you can take, like estrogen. So estrogen can thicken the lining of the uterus, and you can also rely on your own body's estrogen to thicken the lining, so you're not taking it internally, meaning like exogenously, where you're swallowing a pill. And as far as how you can get your body to make more estrogen, you would take a fertility pill to ovulate more than 1 egg, and sometimes that can help. So that's what I would think about. As far as trying progesterone before going to a specialist, I don't know that progesterone would really fix the lining issue. Progesterone just, affects the receptivity of the lining and will make it more likely for an embryo to implant, but progesterone won't necessarily increase the thickness of the lining. So talk to your doctor about your AMH levels. Don't waste time seeing someone who isn't going to look at your entire picture, and do a TUSHY check as well. So for those of you who are like, why does she keep saying TUSHY? That's really weird. I don't know why I'm here listening to her. Go to tushymethod.com and you'll see exactly what I'm talking about. This next question is from Kay, and Kay says, hi, Dr. Aimee. Thanks for answering my previous question about my IVF pyramid and traveling during COVID pre and post FET. I forgot to mention that I'm not from the U.S., and thankfully the COVID situation where I'm from has improved enough to allow local air travel. Just an update, out of the 4 blasts we sent for PGT, only 1 was euploid. My day 8 lining scan showed no polyps, trilaminar, 8 millimeter. I almost said no lollipops. That would be fun if there were lollipops in your uterus. Not fun. That would be uncomfortable, actually. The doctor assumed we're all set for transfer on December 17th, so she didn't offer the option of banking more embryos. When I brought it up, she said the decision to transfer or cancel and do another stim were both valid. Based on my AMH of 4.6, she didn't think my current reproductive stage would change that much in a year despite my age. So I would be okay to try IVF again, even after giving birth if we're successful. If we're inclined to transfer, but if you were me or my RE, how would you approach this decision? So, Kay, I would go ahead and do another cycle now. I tell people, like, over the age of 39, you have to just say there's a chance that I may not make normals each batch anymore. especially the fact that you had 4 blasts, got 1 normal now at 38. Why do way more cycles to potentially get 1 more in a year from now when you can do it now? So I would say, do it now. Easy. Thanks. This next question is from Livia. I'm 33, my AMH is 1.72. My husband's 34 and is positive for a genetic disease. We decided to pursue IVF in order to prevent passing this disease on to our children. It just took us 6 rounds of IVF to get 3 PGTA, PGTM normal embryos. HGH was added to my protocol, which has helped us get more embryos to blastocyst to test. We've transferred all 3 embryos separately this year, the first implanted but ended in a biochemical pregnancy. The last 2 transfers failed. My transfer protocol has been 2 milligrams of estrase 3 times per day at the beginning of the cycle, then 100 milligrams endometrium 3 times per day, and 16 milligrams of Medrol per day for 5 days before transfer. For the last transfer, I also added an aspirin, 81 milligrams as well. I do acupuncture, had an ERA and saline sonogram before my first and third transfers, and my lining always looked good at 8.5 millimeters. My doctor doesn't see any reason why I shouldn't be able to carry a baby. Are there any protocol changes or testing you recommend? So Olivia, I do think that silent endometriosis could be an issue. It sounds like the reason why you're doing PGT A&M is because A&M, that's like A&M University, is because of the fact that your husband has this genetic disease that you want to prevent passing on. But it's possible that all the cycles that you've done could have stimulated some endometriosis. And believe it or not, I think that there might be a situation where that could affect implantation. So in this type of scenario, what I would consider doing is maybe doing another biopsy, looking at the receptiva results and seeing if that can guide your doctor. The question is there silent endometriosis, yes or no? The other thing that I would look at is the quality of your embryos. Look at that and see if somehow the quality is on the low side. Then you would have an answer as to why the embryos aren't sticking and growing. When I think of recurrent implantation, I call them issues, but I know in the literature they're referred to as recurrent implantation failure, and I hate the word failure, so I just call them issues. Some doctors think that there might be a role for a drug called Lovenox, which is a blood thinner that you would take as an injection every day. The other thing is if you don't want to do the receptiva test, there's another protocol that you could use where you do Depo-Lupron for 1 month, overlapping with Femara, 2 milligrams. Femara, another name for it is letrozole, 2 milligrams, or 2 tablets per day. They're 2.5 milligram tablets. And you do that, and then you move forward with your transfer protocol. So looking at the number of embryos that you have left, it sounds like you have 1 embryo left. So I would possibly just do it all. And it sounds like you've literally done it all and you've worked so hard. And I still think that there's some other options for you guys to consider. So I'm so glad you asked me this question. This next question is from Angela. Angela says, what do you think my chances of success are with an IUI? Here's the deal. I'm 37, my husband is 40. He previously had a varicocele and subsequent surgery in 2014. I've already been through IVF with ICSI pre-surgery and it yielded our first son. Post-surgery, I got pregnant on my own and had a second son. I was shocked to learn his morphology plummeted in the last few years and it's gone up 27% since surgery in 2015. We did an ultrasound to look for a recurrence of the varicocele and it came back normal and no varicocele was present. He's on CoQ10 and I'm hoping an IUI could work. I don't want to do IVF again. Thank you so much. You're a fertility angel. Aw, that's really sweet. Thank you for calling me that. I like that. Fertility angel. I actually have lots of fertility angels around here. There's actually one over here. I'm going to go grab it and show it to you guys. Someone gave me this as a gift. And actually, she gave birth today. That's a coincidence. She sent me a really sweet message with pictures of her in the delivery room. So thank you for allowing me to share that nice moment with you guys. Aw. Yeah, I know stuff like that makes me cry. So Angela, back to your story. Here's what I would do. The sperm DNA fragmentation test, super easy. They're going to send you a tank that looks like something that washed up at shore, maybe in Gilligan's Island, not even like shore. I mean, it looks so like out of, I don't know what, like 1970. It's this big bulky tank. It looks like a mushroom and you're going to be like, what? I'm supposed to send my sperm in this to who? And yes, it is a pretty good test that tells us about what I just said, DNA fragmentation. Based on the score, you'll know if it makes sense to continue IUIs or not. The other thing I would do is just go to ballsmethod.com, and I know you've ruled out the varicocele, but also look at his lifestyle, his labs like testosterone, see what other supplements he can be taking. Conception XR through the Theralogics.com website. You can use PRC code, all caps, TUSHY, just like it sounds, for the PRC price, but that's something that he can also take in addition to the CoQ10 that could help. If the sperm count is low, I would consider adding medications like Clomid, gonal F, ACG, but a sperm count is pretty high at 217 million with 65% motility. It seems like it's just the morphology that's on the low end. So if the DNA fragmentation looks amazing, then I would say, maybe this could be actually an egg issue and not so much the sperm issue. And what I mean by that is at 37, it gets harder to get pregnant. Duh. I know, so annoying that I'm saying something that's so obvious, but I think it may not necessarily be all sperm. But you bring up such a wonderful point in kind of describing your situation, because it's obvious that every embryo takes an egg cell and a sperm cell. So I think it's really nice that you're allowing me to kind of talk through all this stuff for other people so they can know what kinds of things to look for when it comes to sperm. And the other thing that I always tell people is, if you got pregnant from an IUI, guess what I want you to do? Free sperm. Because if you want to have another baby in like 2 or 3 years, or even if you got pregnant with IVF and don't have any leftover embryos and the diagnosis was male fertility, I want you to free sperm, so that in a couple of years, if you're ready to get pregnant again and you don't have any embryos left, or you want to do IUI, you have backup sperm from when you guys were younger, especially when he was younger. And doing a sperm freeze is so much easier than an egg freeze, obviously. Okay. This next question is from Nicole. Hi, Dr. Aimee. I just had my first FET of a day 5 blast. It was tested, and so far I feel nothing. Is that normal? I'm trying to talk myself into feeling implantation cramping or something. We transferred with a lining that was 6.4 millimeters and trilaminar and healthy looking. Healthy dooking. I don't know what word that's supposed to mean. Although my doctor said it thickened up on transfer day. The thickest I've ever gotten before is 6.8. So that's just my body. Thoughts on transferring below 8 millimeters? Nicole, it would be so mean for me to be like, I wouldn't have transferred that way, right? Like, so mean, because you just did a transfer 2 days ago. So I'm really, really hoping that you're going to have some excellent news here soon. But I would say if this next transfer didn't work, look and see how many embryos you have, and then maybe consider making more before you do another transfer. It might take a little bit more work to get your lining even thicker, and see what you and your doctor can come up with a plan. You guys know part of my sparkle checklist is the L, which is the lining thickness during your IVF cycle. So go back to your doctor and be like, how did my lining look during my IVF cycle? What was my lining on the day of the egg retrieval? Or not necessarily the retrieval, because we don't necessarily check the lining on the day of the retrieval. What was my lining when I did my trigger shot? Because you might be someone that would do better with a stimulated natural cycle. Stimulated natural cycle just means taking hormones to get your eggs to make the estrogen, to talk to your lining, to talk to the embryo, to talk to the, that sounds really fun for me to say, talk to the, so everyone's talking to each other. But the reality is your ovaries can maybe do a better job than the estrogen pills that you'll take. So see what your doctor says. And I hope it's going to be a non-issue, because I hope this transfer works and everything's going to be okay. Okay, this question is from Mina. And Mina says, hi, Dr. Aimee, love your show. Thank you for taking my question. I'm 34, almost 35, with PCOS, regular cycles with my inositol. I just found out my third FET failed. I used PGS tested embryos each time. My first one's the biochemical, and my second and third had no implantation. This cycle, I did an ERA, I was receptive, and hysteroscopy to remove micro polyps, and the biopsy was normal. My lining was 9.7 on day 12, transfer was day 20, used Lovenox baby aspirin, estrogen patches, progesterone injection suppositories, blood work 5 days after estrogen was low. My estrogen was 114. I don't consider that low, just so you know. Progesterone was 55, and they had added another patch, retested. Day 7 estrogen was 219, progesterone 59, and my pregnancy test was negative. What do I do or change before my next transfer, before I do another round of IVF? Okay, so this is really hard. You've had 3 transfers that didn't work. It sounds like your doctor is just constantly thinking about other things that you should be doing. You've done the hysteroscopy. That's super. The other thing that I would do is consider doing the Receptiva DX test. You already did the ERA test. Maybe do another mock cycle and do the biopsy for Receptiva, or just do it in a natural cycle a week after ovulation. Just don't have sex around ovulation so that the biopsy doesn't potentially interrupt a pregnancy. But that's what I would think of doing. I would consider doing that test and maybe seeing if that test will teach you anything. Whenever someone has had a biochemical pregnancy, and you have, I always still go through the Angel Workup. So angelworkup.com has all those things listed in there. but I want to see, do you have, is there a chance that you might have antiphospholipid antibody syndrome? It sounds like you've ruled out a septum already and you've already removed polyps. Make sure that you've checked again before your next transfer, that the polyps didn't come back. Some people just make them very, very often. It doesn't necessarily sound like that's the case for you. And then I would also rule out like a thyroid problem or a problem with diabetes and look at your lifestyle and nutrition status, and then talk to a nutritionist if you need to. But I do feel like there's a good chance that another transfer could, a transfer could work for you in the future. But make sure you've looked at the quality of the remaining embryos that you have and ask your doctor, what is my implantation rate for the embryos that I have, so that you can truly have all the information you need. Because sometimes embryos can be poor quality, even though they're PGS normal, and that's the reason why they actually didn't stick and grow. And that's something that you and your doctor can talk about. So I hope this stuff helps you. This next question is from Mary. And Mary says, hi, Dr. Aimee, love your show and your positive energy. I'm taking cabergoline because of high prolactin. Could this affect the maturity of my eggs during stimulation? Thank you so much. Mary, no, I haven't noticed that cabergoline affects egg maturity. Not at all. This next question is from Elise. Dr. Aimee, not a question. Just want to tell you something amazing. Here we go. We had IVF 11 years ago, and they had 5 blasts, 7 day 3 embryos frozen. We thought 3 of the blasts had died. They did a transfer with 1, it failed. We still have 1 blast. Then I asked my doctor if we can thaw the 7, and we did. 5 survived the thaw, 3 made it to day 5 and got biopsied for PGT and refroze, just got the results. 2 of the 3 are normal, 5AA and 4AA. I'm so excited because I'm 41 years old and had 2 miscarriages, 1 natural pregnancy, and the other one was an IVF, and we got 1 PGT embryo. So happy to transfer one of these in January because, as you know, it's hard to find good eggs in our 40s. I actually like that a lot. It's hard to find good eggs in our 40s. I like that. It's a lot better than saying you have to assume you don't have any good eggs. That's really harsh. It's hard to find good eggs in your 40s. I'm going to have to circle that, highlight that, and make that a hashtag, a t-shirt, a baseball cap, and walk around town with that, because that's some good stuff. See, that's me circling it, highlighting it, all that good stuff. Okay. I'm going to keep you posted, because wouldn't it be so amazing if we had a baby from this 11-year-old embryo? It will be like a twin to our 10-year-old son. Kinda. I think it's cute when people think of their embryos like that. It makes sense. I'll let you know the outcome. In the meantime, I've been on all your vitamin recommendations. So I think the best thing out of Elise's message to me that she sent in through asktheeggwhisperer.com is now you're not going to hear me be so negative if someone says, I'm 47 and I want to try each month to have a pregnancy with my own eggs. Rather than me saying there's a 0% chance that could happen or close to 0, I'm going to say it's really hard to find a good egg at 47. That just feels so much better. And it sounds so much better, right? Okay, Rena has sent in the next question. And her question is this. Hi, Dr. Aimee. Thanks for sharing your wisdom and your sparkly sense of humor with us. Ah, Rena, you know me well. My question is, I've had regular cycles around 31 days and a confirmed ovulation through the OPK and the PROVE test. However, my periods are a bit weird. Here's the story. They start with 3 to 4 days of brown spotting, followed by 2 days of very light red bleeding. I count the first day of red bleeding as day 1 of my cycle. This worries me as it does not align with what I've read online is a good and healthy period. Should I be worried? Are there other levels I should get checked? Or should I just continue to track ovulation and time intercourse as my OBGYN advises? I'm 34, AMH is 2.3, partner semen analysis is good. I've been trying to conceive for 6 months. Rena, it sounds like we're missing something. We're missing the U. Your uterus. What's going on? Pelvic ultrasound, please. That's what I would do next. Ask your doctor for one. Have them order a formal pelvic ultrasound, taking a look at your uterus to see what's going on. Is there a reason why you're spotting like that? Could it be a uterine polyp? That's kind of what I'm thinking. Having 2 days of very light red bleeding, and then the first day of red bleeding is day 1. I mean, maybe that's just your normal, and that's totally okay. But I want to make sure we're not missing anything. One of my Egg Whisperer golden rules is if you're over the age of 32 and you want 2 kids, you've heard people saying, save the eggs, right? Like, get your eggs frozen. But you're partnered. Save the embryos. Of course, if making embryos is, morally acceptable to you, some people have problems with that. I don't, obviously, because this is what I do. And I do believe that if you froze embryos now, You'll give yourself a better chance of pregnancy in the future. We know it gets hard to get pregnant as we get older. It's hard to find good eggs. See what I did? When you're over even the age of 37. And 37 feels so young to me, right? Because I'm not 37. So I look at 37-year-olds, I'm like, you're a baby. But still, I'm going to look out for you and make sure that I'm protecting you and giving you all the information I would want someone to give me if I were 34. So that's what I would do. Go see a fertility doctor, get some embryos frozen, and start having babies. You've already been trying 6 months. There's technology that can help you. But of course, getting pregnant at home, way more fun. Trust me. Okay, this next question is from Maria. Maria says, "Hi, Dr. Aimee. I did an egg freezing cycle October of 2019, 2 days shy of my 36th birthday. Back then, I knew very little about IVF. That's no longer the case thanks to you." Maria, thank you for that compliment. That means a lot to me. "I'm now 37 and we've been trying to conceive since February of 2020, including several medicated IUI cycles. No luck. We're planning on IVF February 2021. Here's my question. For my egg freezing cycle, I did estrogen priming for 14 days. Then cycle day 2, I started Menopur 75, Gonal F 250, cycle days 8 through 12, Menopur 150, 225 of Gonal, 9 through 12, Cetrotide. Cycle day 12, I did my trigger shot. On day 11, my final ultrasound, my 3 biggest follicles were 18, 19, 19, 12 were 14 to 17, 13 eggs were retrieved, 11 mature. Now, looking at my ultrasound report, I see that I had more than 13 follicles between 10 to 13 on day 11. My estradiol level was 2,531. Should we have waited 2 more days before triggering for a better result? What should I do differently next time? My current AMH is 2.38, FSH of 8, AFC 14 to 15. So, wow, that's a whole lot of eggs. So I would say the reason why your doctor probably didn't push you 1 more day is because you were already on cycle day 11 and you had at least 2 follicles that were 18 millimeters or more. And 14 to 17, for me, I would definitely want to know how many were 16 and 17 millimeters. But what I would do differently, I would say no to that long of estrogen priming. So 14 days of priming is probably the reason why you had to cycle and take medications and trigger on day 12. So you were a day 12 trigger. I would estimate that you probably would have used 2 days less of medications if you didn't take so much estrogen for priming. I think your pyramid, what you guys hear me talk about, your pyramid actually was really a good pyramid for what you described. It sounds like they maximize your chances. You didn't get sick from the procedure. But I would say this time, yes, see if they would push you 1 or 2 extra days, of course, if they feel like it would be safe for you and you wouldn't have severe OHSS. And take your CoQ10. Okay. This next question is from Mo. And Mo says, "Hi, Dr. Aimee. Thanks in advance for answering my question. I've done 2 rounds of IVF. The first cycle I did an antagonist protocol with 75 of Menopur, 150 of Gonal. I was trying to see how fast I could say that without messing up. Clearly, I couldn't say it too fast without messing up. Cetrotide and a trigger with Lupron. I had 19 eggs, 16 mature, and none fertilized. Our doctor was convinced that ICSI and a modification to the protocol would address the fertilization issue. For my second cycle, I was put on an agonist cycle, starting with Lupron, and then 75 of Menopur, 75 of Gonal F, and I triggered with HCG. 28 eggs were mature out of 29 retrieved. ICSI was performed, and still, no eggs fertilized. My doctor indicated this is really rare and wants to do another cycle whereby we only try to retrieve 4 to 5 eggs. My AMH is 6.5, FSH 8.1. Why do you think we can't get any eggs to fertilize? Are there any tests that could be done to determine what is the issue? And do you think a mini IVF is the best approach?" Mo, that's really heartbreaking. I'm really sorry that you've gone through 2 whole IVF cycles with no eggs fertilizing. So my sense is that this is probably sperm driven. There's probably some sort of gene variant that your husband's inherited, and it's not like something that you can look at by looking at the sperm. But I bet there's some sort of gene issue there. I think you might need something called calcium activation of the eggs, and you can't just do it anywhere. Not all labs can do it or know how to do it. You don't want someone just flipping through the, textbook to figure out how to do it the first time for you. Ask your doctor about that. Ask your husband to do a sperm DNA fragmentation test, and I would have both of you do chromosome testing. So that's kind of where I would start. There's some pretty advanced fertility gene tests that you can also do if you want through Fulgent or phosphorus.com. So those are additional tests that your doctor might want to have you do. But that's the next step. I would do sperm DNA fragmentation testing. I would consider having calcium activation as a tool in the toolbox that your doctor uses during your next egg retrieval. But my sense is that this might be more sperm-driven than egg-driven. That's just my gut, especially because of the number of eggs that you have. Could it be egg-driven? Possibly. I would say there's really not a way for us to know that for sure. The only way to know that for sure is if we switched out the egg source, used a set of frozen donor eggs, and fertilized them with your... I don't know why. I'm having a hard time saying fertilize today. Everything's fartilized. Maybe it's because every time you say fart, you laugh, and I just feel like laughing right now. But I would say that might be another strategy where you took, let's say, 6 frozen donor eggs and fertilized them with your husband's sperm. I know this is no laughing matter, you guys, like, believe me, but I'm just being silly. And then see what would happen from there. But that's just my suggestion for you. And I feel like you would have a really good chance with that extra modification. And then there's Zymont and there's Pixie. Those are 2 other tools that your doctor can use as well to treat the sperm before they inject your eggs. Okay, this next question is from Lisa. Hi, Dr. Aimee. What are your thoughts on transferring multiple embryos on day 3? Fresh, especially for a woman that's 44 to 45 years old. In your experience, do the odds increase of having at least 1 embryo stick when transferring 2? I'd transfer even 3 or heck the entire batch if it meant my chance of at least 1 sticking went up. LOL, thanks for your advice. Lisa, absolutely. The most number of embryos that I've transferred to someone over the age of 43 is 8. Yes, 8 embryos. They didn't get crowded in there. Embryos are microscopic. They're teeny, teeny, tiny. You can't see them with the naked eye. And yes, this one patient that comes to mind that I did that for, she got pregnant with 1 healthy baby. So let's just say I have a 44-year-old right now, just hypothetically, and she has 5 embryos and all 5 turn into blasts. Probably that won't happen. Typically, the blast formation rate is going to be around 50, maybe 60%. Let's say I get 2 to 3 blastocysts for a fresh transfer. I would transfer all of them. Not because I think I'm going to put her at risk of having twins or triplets, but just because I think that would give us the highest chance of having a single pregnancy. This next question is from Whitney. Here's Whitney's question. Can you elaborate on why you are recommending pregnant women get the COVID vaccine? There's so much conflicting information since it wasn't tested on pregnant women, so I'd love to hear your thoughts. Whitney, I have unfortunately seen COVID complications in my pregnant patients, and we know that COVID complications are much higher in pregnant women than non-pregnant. So since I have personally seen that happen, I want to do anything and everything to prevent any of my pregnant patients from getting COVID, number 1, and that includes getting the vaccine. So that's why I recommend it to my pregnant patients. So next question is from Anna. Hi, Dr. Aimee. I work in healthcare and will be offered, this is just like Whitney's question. I'm offered the COVID-19 vaccine through my work. Is the vaccine safe for those who are trying to conceive? Anna, I would have a conversation with your doctor to make, to kind of talk about what's right for you, for sure. But I don't see any indication that the vaccine would cause infertility either in men or women. Thank you, Anna, for that question. Nisha is saying, my clinic does 2 biopsies for an ERA cycle. My report came back non-informative. It did not match any data. I'm in the middle of my 2nd ERA cycle now, even though the FET should have been next week. Have you ever seen that happen and why? Nisha, when a result comes back non-informative, it doesn't mean that there's anything wrong with you. You're a very informed person. It means that someone didn't screw the top on the ERA vial, literally. Like it means some of it spilled out in transport. Or it wasn't handled properly, like it got too hot or too cold before it was transported. Non-informative almost never means that there's anything wrong with you. So typically that's what non-informative means. It's code for someone spilled the vial, or it wasn't screwed on right, or it was too hot and they didn't put a cool pack, or the opposite, it was too cold and they froze it and that affected the sample. So I'm sorry that happened to you, but it's okay. It's a good learning experience to still do the test. And I've had that happen before. I had 1 week, this was maybe about like 5 years ago, where I had 5 tests that I did. Every single one came back non-informative. It happened to be a week where it was over 100 degrees here in California. And I was like, what the heck? I've been doing this test for like already 5 years and I've never had a single non-informative. And they're like, oh yeah, like we forgot to tell you that when it's over 100 degrees, you need to put the sample on a cold pack and then ship it. I'm like, really? Like, really? And I literally had to do another test on every single person, and that has never happened again. So hopefully that will not happen with your second ERA test, Nisha. This next question is from Jennifer. Jennifer says, "Hi, Dr. Aimee. I'm so thankful for your show. It helps me more than you know." Jennifer, that's why I'm here, so that I can help people just like you. No matter where you are in the world, you can hear some of the things that other people are asking. My answers, I don't know that they're that important. I'm just giving answers just based on what I would do in your situation, not to replace the advice of your doctor. But I think hearing other people's questions make you realize that you're not alone. Other people are going through the same stuff that you are. And it makes you realize that, like, wow, like this is part of the normal human experience. I mean, it sucks, like, don't get me wrong, but we have to normalize this stuff, and it certainly is normal. Okay, here we go. I'm 33, not a mother yet, going down the solo route with sperm donor. Was all set to have an IUI, then a hysteroscopy showed my fibroid had grown to 2.5 centimeters from 1 centimeter in a year and was bulging in the cavity. My tubes are also blocked. I got referred back to my gynecologist to have the fibroid removed. He couldn't understand why my tubes were blocked since I have no history of sexually transmitted infections, and my previous laparoscopy showed no endometriosis. Out of all the options for removal of the fibroid, myomectomy seems the best way to go. My question is this: for the possible chance to conceive IVF or IUI, would you do it laparoscopic or open? I wouldn't be opposed to having my future child by C-section. The gynecologist will also carry out an HSG to check my tubes again. He thinks that the reason why my tubes are blocked is a false positive. Thanks so much. You're the best. Jennifer, I think that if the fibroid is bulging in the cavity, there's a good chance that you can actually remove it from below, meaning you don't need to have an open myomectomy. So ask your doctor, is there a way that I can have it removed through something called a hysteroscopy, and see what they say? Because if it's bulging inside the cavity, that means it's like this, like, hello, bulging. Let's see here. I'm a fibroid. Bulging inside the cavity. So if it's bulging like this, then you can come from here and scoop it out with a little morcellator. And the morcellator that I use is from TruClear, TruClear, and you can literally go to YouTube, put in TruClear myomectomy, and you can watch videos. Don't watch them if you have a sensitive stomach. Trust me. Some people don't even like to watch stuff like that, and I totally get it. So that's what I would see if you could do. See if they could do it hysteroscopically rather than open or with a laparoscopy. As far as open or laparoscopy, whatever your doctor thinks is the best for them, right? So you have to ask the surgeon and say, like, which procedure are you the best at for this diagnosis? Like, we don't want to tell them what to do necessarily. We want them to do what they're best at, so you have the smoothest recovery and healthiest pregnancy. And I think, checking the tubes at the time of surgery, I'm not sure that that's going to be really that helpful, because all that uterine manipulation, even if your fallopian tubes are blocked again, it might be one of those scenarios where it's because of the manipulation of the uterus that blocked them. And then check your AMH level, because it might be helpful to maybe consider doing IVF first and then all this other stuff later. Because if the tubes are indeed blocked, I wouldn't want you to waste like all these months if your egg count is low on, researching the fibroid, which obviously, like, I want you to research the fibroid, don't get me wrong. But I'm just thinking it might make sense to do IVF first, then remove the fibroid, and then depending on how long they want you to rest, sometimes if it's a really, really big fibroid bulging in the cavity, they want you to wait 6 months to transfer. But sometimes you can transfer 1 to 3 months later. It just really depends on what your doctor says. So that's what I would be thinking for you. But it totally makes sense for them to want to check the fallopian tubes again when they're in surgery, because obviously if they're open, that would be great. You can do IUI. But my concern is that there is a risk of blocking of tubal blockage even from the surgery. So knowing your tubes are open at the time of surgery doesn't necessarily mean that the tubes will stay open. And knowing that the tubes are blocked at the time of surgery doesn't really mean they're blocked, because of where the fibroid is potentially located, and manipulating the uterus can make them seem blocked when they really aren't. I hope that helps. Okay, guys, well, thank you for being here. I'm going to just go through your chatted questions, and I'm going to run home. Let's see here. So first question is from Marianne. Endometritis, first biopsy, greater than 15 plasma cells. And then my next biopsy, 4 plasma cells, now on metronidazole, Keflex, would you repeat the biopsy? And if you're a patient of mine, I would say no. It sounds like that you're seeing improvement, and I would stop the biopsies. Gabrielle says, get pregnant first PGS FET for future transfers, or got pregnant with my first PGT FET. For future transfers, is it possible I might experience recurrent pregnancy loss even though I didn't with my first transfer? And Gabrielle, I would say the likelihood is still there. It's possible that your next transfer results in a miscarriage in the future. I really hope not, but I don't think that this is necessarily something that you have to worry about. I think it's normal to have these kinds of worries though, because that's just like what we do. Next question is from Annette. Do I need to be laying down when inserting vaginal suppository? Do I need to be laying down for a period of time so it doesn't leak? Annette, I got news for you. It doesn't matter if you're laying down or not. That stuff just leaks. I mean, I guess if you're lying down all the time, maybe not as much will leak, but with gravity, the stuff just comes out, and maybe even without gravity. So I don't tell my patients to lie down when they place their vaginal suppositories. Okay, next question is, hi, Dr. A, I'm 5 weeks tomorrow, and so far my HCG is doubling every 48 hours. This last check, my HCG increased 76%. Is that still good, even if it doesn't exactly double? The answer is yes. That is really good. Next question is, you mentioned yesterday that you discuss a biopsy with all patients. What do you say when recommending and discussing doing the biopsy before transfer? This is easy. I have something called the Egg Whisperer diet, okay? Diagnosis, IVF, endometrial preparation, which is the lining of your uterus, and then transfer. So I always want to talk to patients about why we're doing IVF and the protocol we're using and why based on their diagnosis. And then when we're done with the IVF cycle and we've created embryos, I always ask the question, do we have enough embryos for the family size that you want? Yes or no? And what would we do if this next transfer didn't work? And most of my patients are over the age of 37, especially over the age of 40. We work so hard for each and every embryo. No matter your age, every embryo is precious. But if my patients are so lucky to have, let's say, 4 or 5 embryos and they want 1 or 2 kids, well, then we'll just go right into a transfer. At least I'll offer them that. Sometimes people will still want to do the implantation testing. But if you have the exact number of embryos as the family size that you want, or I should say the exact number of high quality embryos for the family size that you want, then we do the extra tests. So that's how I talk to them about it. Next question is from Nassim. Hi, Dr. Aimee. Just figured out I have a 3 centimeter intramural fibroid. Oh, actually, I have 3 intramural fibroids, size of 1.5, 1.4, 1.9 centimeters. What is the best intervention before starting a cycle? So Nassim, intramural just means they're like freckles on your face. They don't affect your fertility. Submucosal is what we care about. So if they're impinging on the cavity, pushing in, bulging the cavity, making it distorted, that's a different story. We want them to find a home in a jar, not in your uterus. Next question is, I have 8 embryos. Only 1 is normal. It's grade BC. We're not diagnosed with any fertility issues. I'm 39. He's 43. Contemplating percentage of success on this transfer of my only embryo or try another round of stimulation. So what I would say at 39, you know your fertility issues are due to age. It's really hard to find a good egg at 39. See? There's nothing necessarily wrong with you. This is a natural fertility aging issue that everybody has. So I would say you're quite lucky to have this normal embryo. And I would say do another IVF cycle now, just so you have more embryos for the future in case you want another baby. Next question is, can you please recommend an IVF clinic and provider in Massachusetts? I absolutely can. I love CCRM in Boston. Dr. Allison Zyman is fabulous. I love Dr. David Riley at Boston IVF, Dr. Allison Zyman, not Allison Zyman, Allison's at CCRM. I love Dr. David Riley at Boston IVF. I love Dr. Rita Sneeringer at Boston IVF. There's so many wonderful Boston IVF clinics. I love Dr. Irene Suter at MGH. All of them are my friends, and they're awesome. Next question is from Gabrielle. Gabrielle, is a higher than minimum needed lining better as it increases FET success? The answer is, I don't necessarily think your implantation rate increases the thicker your lining gets once it's above 9 millimeters. However, I do think the implantation rate decreases as you are below, the lower you go, below 8 millimeters. Next question, is there a particular brand of prenatal you recommend? And the answer is yes. It's Theranatal through Theralogic website. Use the PRC code TUSHY, all caps for that one. And they also have a magnesium supplement that is safe in pregnancy as well. Next question is for post-FET meds, is it okay to stop aspirin? I started taking it since my FET, but my stomach couldn't tolerate it and the discomfort kept me up at night. I'm also anti-TPO positive, but TSH is normal. Yes, so what I would recommend doing is stop the aspirin. It's okay. Having reflux and stomach acid is horrible and it's going to keep you up at night, so I would stop it. So talk to your doctor first before you do so, obviously, because my advice is not here to replace your doctors. But if you were a patient of mine, I would say stop it. And you can also take Tums and see if that will help. I also give some patients Pepcid as well. Someone just said, I just chose watching your show right now over a dating show. Thank you. That's really funny. What causes DNA degradation for biopsy samples sent for PGTA? It could be related to the processing and handling of the sample at the time of biopsy or once it arrived at the genetic testing lab. So someone just said, Heather says, hi, Dr. Aimee, my transfer was a success. Congratulations, Heather. That's awesome. Next question is PCOS, failed frozen, second transfer canceled because of no trilaminar layers. Any way to get trilaminar layers? Yeah, I mean, I think it just depends on how much estrogen you're taking, the mode of administration. Sometimes people respond better to different modes of administration. I think the Vivel patch or I think it's the dot, like there's so many different names for the generic version, not genetic version. So talk to your doctor about switching you to a different form of estrogen in your body. It might actually like it better. Next question is, hi, Dr. Aimee, for egg quality, when do you recommend starting Omnitrope? I'm 44. We're doing IVF number 6, mid-January. Last round, we got 8 eggs, 7 fertilized, transferred 2 on day 3. They didn't take. Those are pretty good numbers, Chicago honey bear dancers. I just like saying that. And I like looking at that. It just makes me smile. So as far as that, I would start HGH now ahead of your stim start and do it twice a week. And then when you start stim, ask your doctor if they have good experience with patients taking it every day rather than just every other day. So Nassim says, every single one of your answers opens a new window to me in this journey. Big thanks. Thank you, Nassim. That's really, really sweet of you to share that with everybody. Hi, Dr. Aimee. How many normal embryos do you recommend for a desired family size of 2? I'm 36 and currently have 2 normal embryos. So I would recommend doing 1 more cycle because you just don't know what's going to happen in the future. So that's what I would do. That was an easy question to ask. Okay, last comment is, you're an angel. Thank you for all you offer. Happy holidays and stay safe. Thank you. Okay, last question. Can a uterus be prepared okay for transfer around age 49 or 50 with donor egg, donor sperm? The answer is yes. I have a lot of patients, and I imagine that in 10 years from now, all my patients will be over 47. Right now, most of my patients are over the age of 37 with my average age between like 40 and 42. So I think in 10 years, everyone's going to be 47 wanting to have babies. And so yes, you can absolutely get your uterus prepared. And I actually have a website, surprise, surprise, menopausalpregnancy.com. I did just say that. And it's totally normal in my world to help women who don't have eggs anymore, because it's really hard to find a normal egg at 49, and creative family building options are what I also specialize in. So the answer is absolutely yes. You can prepare your uterus for a transfer using, we call that double donor embryos. Next question is, would it make sense to rebiopsy the embryo that resulted in DNA degradation, or is it out of the game? I personally have a hard time repeat biopsying embryos unless it's like there's a really compelling reason to do so. Otherwise, I would leave that embryo alone. I have double biopsied. I probably double biopsy maybe like 1 or 2 embryos a year, but very careful counseling and consideration goes into that decision, because I do think that doing the double biopsy could potentially reduce the implantation rate, and I wouldn't want you to do that to the embryo unless you knew that first. Okay, guys, I'm done. I'm going to run home right now, and I can't wait to be here again next week. I hope you guys all have a great night. Keep sparkling. I know you're like, oh my God, I cannot believe she just said that. That is so nauseating that she's so irritatingly positive. But honestly, my job is really, really hard. I cry a lot most of the day. Not a lot. I would say I shed a few tears most days. And that's because that not everything I do is sunshine and roses and puppy dogs and unicorns and fairy tales and sprinkles and sparkles. Honestly, it's quite hard because all of the questions that you guys are asking me, I'm living through those stories each and every day here in my office. So I always tell people I work superhero hours, but I'm not a superhero. So things affect me and hurt me just like they hurt the people that are asking these questions. So I'll just do a plug for mental health awareness. So please find help if you need to. Please connect with other people around you. Make sure you're talking to someone who will listen and not use words and give their feedback and input. So like my sister, I'm always talking about my sister on this show. She'll call me and she'll start talking and I'll start to try and give her advice. And she's like, I didn't call you for you to give me advice. I just want you to use your ears and not your mouth. Use your ears, not your mouth. Shh. And then she'll hang up on me and I'll call her back. And then I'll say, I'm ready to use my ears and not my mouth. What were you going to tell me? Okay, guys, I hope that made you laugh. I love you all and have a great night. Talk to you soon.